and it was awesomeness oozing all around when Rajat sir was talking. Now, the job entrusted with me by ISA is really Herculean, because respiratory physiology, as you know, is vast, and um, it is not possible to cover the entire respiratory physiology in one session. And more than that, it is really challenging to keep it short and sweet, and equally challenging to keep all the listeners from falling asleep. So I have decided to split the topic into two sessions. The first one being today. I am going to deal with just the very basics in today's session, the basics in respiratory mechanics. And in the next class, I would go on with little more complex aspects of respiratory mechanics and overall the respiratory system. My screen seems to be stuck. I'm sorry, 1 second.
Go to slideshow once again.
Yeah, the problem with my system here, it seems to have frozen.
No problem. We'll just shut down and once again share
Okay,
the
1 second.
no issues.
Okay, so greetings from Rajagiri Hospital, and you can see our beautiful campus appears more beautiful in this monsoon season. It is oxygen all around. Our lush green campus, you inhale a lot of oxygen, and definitely a breath of fresh air is everyone's dream. And we will see how a breath of fresh air actually reaches everyone's body. Now, we'll move on to the respiratory mechanics as such. Air moves in and out of lung by cyclic action of respiratory muscle. So this is what we call as breathing. So each breath starts with pressure applied by respiratory muscle, uh, which causes a negative pressure, or by a ventilator, where actually it gives a positive pressure. So it generates a flow of gas through airways, either by a negative pressure or by a positive pressure from ventilator through the airways, which expands the volume of lung and the surrounding structure. Surrounding structures means the chest wall and the pleura. So this process depends on three things. One, the respiratory muscles and their actions, the compliance of the chest wall and lung, and the way the gas flows in the airway. So we have to keep in mind these three aspects, and our entire discussion this evening is going to be around these three aspects of respiratory mechanics. One is how the respiratory muscles um, are involved in breathing, and how the compliance of chest wall and the lung affect the breathing, and how the gas flows in the airway dictates how oxygen or gas is going to flow in the airway. Now we'll come to respiratory muscles. Usually, it is during inspiration, the respiratory muscle play a bigger role. The major respiratory muscles are diaphragm and accessory muscles. We'll come to diaphragm because that is the principal muscle of breathing. and accounts for 75% of the air that enters lung during spontaneous inspiration. Now, more than two-thirds of diaphragm has slow twitch fibers, which, as you know, are resistant to fatigue. The contraction of diaphragm moves the abdominal contents downwards and forwards. So that creates a potential space in the thoracic cavity, creating a negative pressure and um, taking the air into the lungs. When it comes to accessory muscles of respiration includes external intercostal muscle, sternocleidomastoid, the anterior serratus muscle, the scalene muscles. Now, what we have to keep in mind is contribution of these accessory muscles during quiet breathing is very small. Accessory muscles play a bigger role when the respiration deepens because you need to increase the space in the intrathoracic cavity. So it increases by expanding it in all direction, that is in lateral and anteroposterior direction, not only in the Z axis, as done by the diaphragm. Now we come to what happens during expiration. Expiration is usually because of recoil. The diaphragm relaxes. The elastic recoil of lung, chest wall, and abdominal structures compress the lung. Um, Forced expiration for a cough or when airway resistance is increased requires abdominal muscles and internal intercostals also. Now, this diagram is a schematic representation of what happens during inspiration and expiration, how the muscle acts. Now, as I said, the contraction of the diaphragm, the dimensions increases in an Z axis. That is, it pushes the abdominal contents down, creating a space. Now, the intercostal muscles create a side to side, that is a lateral and anteroposterior increase in the diameter by elevating the ribs and sternum, and creates more space when there is a need. Now we'll come to the second aspect of mechanics of breathing, that is compliance of chest wall and lungs. Now, you all know lung and thoracic cage expands and contract together. So that means lung and the chest wall move together as a unit. Now, lung expands in response to a pressure gradient that is produced across its surface. This is called the transpulmonary pressure. We'll come to that later. Now, what we have to keep in mind is transpulmonary pressure is equal to the difference between airway pressure in the lung and the pressure on the lung surface, that is between the lung and the chest wall. This is known as intrapleural pressure. So transpulmonary pressure is equal to airway pressure minus the intrapleural pressure. Now, airway pressure will almost be equal to the atmospheric pressure in most of the times. We'll come to intrapleural pressure. The resting position of the lung and chest wall occurs at functional residual capacity. That means the lung and chest wall recoil forces will be at equilibrium at FRC. So suppose if you are dealing with an isolated lung, the lung would collapse to a volume less than FRC. And the thoracic cage would then have a volume more than FRC. So at FRC, these two forces will be at equilibrium. Now, when it is at equilibrium, this produces a negative pressure in the pleural space. This negative pressure on normal inspiration, the negative pressure further reduces. In forced inspiration, it can go fall up to -4 millimeter mercury. Now, we'll come to the term of transpulmonary pressure. During spontaneous respiration, airway pressure in lung can be approximated to atmospheric pressure. The pressure on the lung surface is the intrapleural pressure. So this is equivalent to a distending transpulmonary pressure. Now, this diagram explains it much better. You can see um, the structure of lung. There is the thoracic wall. You have the parietal pleura, the visceral pleura, and the intrapleural pressure. That is actually the difference between the between the airway pressure and the intrapleural pressure, which normally is 4 millimeter mercury. And you have the transpulmonary pressure, which is almost similar to the atmospheric pressure. So the lung expand in response to the transpulmonary pressure that is produced by the respiratory muscle. The amount of expansion for a given transpulmonary pressure represents the ease with which the lung expands. So this property is measured by lung compliance. The term lung compliance is used to denote this. So lung compliance can be loosely termed as change in volume divided by the change in transpulmonary pressure. Now we'll see the factors affecting the lung compliance. Now from this list, you can see the compliance is maximum at normal FRC. At normal FRC, the recoil forces, as I told before, will be at equilibrium. So that gives maximum compliance. And also when the patient or when the subject is standing. Those who are singers would know, standing, you will be able to sing very high notes very easily, but at the same time, you attempt singing at lying down position, you won't be able to take that high octaves or high notes. The compliance decreases. In supine, in infancy, in elderly, in pregnancy, in disease conditions like ARDS or pulmonary edema, the compliance decreases. Now we'll come to another term, pressure volume loop for respiratory system. These are basic things which I want to impress upon you so that when we discuss the implications of these things, it will become easier. Now, if a pressure volume curve for respiratory system is plotted through a cycle of inspiration and respiration, a loop that is obtained as inspiratory and expiratory limbs of curve do not exactly coincide. So this gives the appearance of a loop. This loop effect is otherwise known as hysteresis. Now, the area of the loop represents wasted energy. Wasted in the sense, the energy that is wasted because of loss during stretching and recoil of the tissues, and frictional loss due to airway resistance. So as the loop increases, the wastage of energy increases, the work of breathing increases. Now, the body does body has its mechanism to reduce wasted energy, and that is where the role of surfactants come in. We'll deal with all these things at a later stage. Now we'll come to some relevant anatomical aspect. Now, as you all know, the airway is divided into two. One is the gas conducting system, and the second is the gas exchanging components. The gas conducting segments of the airway goes up to 12 or 16 generation of the bronchioles, and the gas exchanging components usually starts from the 17th or 19th generation to alveolar duct and alveolar sac that goes up to the 20th or the 23rd generation. Now, you have to keep in mind about the alveolar capillary membrane. This is very important when we discuss the pathological states in the next session. Now, alveolar capillary membrane is where the gas exchange occurs. This is otherwise known as a blood-gas barrier. Also, there will be fluid exchange between the alveolar interstitial tissue and the capillary lumen. We'll come to larynx. You all know the anatomy of larynx. I'm not going to go into detail, but I want you to keep in mind the three main functions of larynx. One is regulation of respiratory airflow, otherwise known as respiratory braking. This is important for vocalization, coughing, and control of end expiratory lung volume. Now, protection of lower airway. Vocal cord closure prevents aspiration of foreign materials or objects. The end expiratory braking, as I told you before, allows cough reflex to expel foreign bodies and secretion, which plays a major role in protecting lower airway, and of course, vocalization, as we all know. Lung volume, we have been hearing about it right from our physiology days. The total lung capacity, which is from about 4,200 to 6,000 ml. The tidal volume, that is normal amount of gas inspired and expired during quiet breathing, approximately 500 ml. The inspiratory reserve volume, that is extra volume of gas that can be inspired over and beyond the normal tidal volume, which is usually around 1,900 to 3,300 ml. Now, residual volume, that is the amount of gas remaining in the lungs at the end of maximal forced expiration. Then the vital capacity, that is maximal volume of gas that can be expelled after maximum inspiration. The functional residual capacity, the lung volume following expiration during a quiet breathing. Now, we'll discuss in detail vital capacity. Vital capacity is a maximum volume of gas that can be expelled after a maximal inspiration. The factors that determine vital capacity is body size, strength of respiratory muscle, chest and lung compliance. Important clinical measure of respiratory insufficiency, particularly in patients with restrictive disease. So vital capacity of less than 10 ml per kilogram is indicative of impending respiratory failure. We'll come to a very important term of functional residual capacity. FRC is a lung volume at end of quiet normal breathing. So FRC is usually the sum of expiratory reserve volume and residual volume. Now remember, resting volume of thoracic cage is usually more than FRC. A normal lung volume is FRC. As we have discussed before, at FRC, there is an equilibrium between the recoil forces of lung. So that means this is the equilibrium point between the tendency of lung to collapse and the thoracic cage to expand. Now, what we have to keep in mind is this is not a fixed volume like the other volumes and capacities. This FRC varies with a lot of factors. Now, the factors affecting FRC: age, posture, anesthesia, surgery, pulmonary fibrosis, pulmonary edema, obesity, abdominal swelling, thoracic wall distortion, reduced muscle tone, all decreases FRC. In conditions where lung volume increases, like positive intrathoracic pressure, emphysema, bronchial asthma, you can have increased FRC. Closing capacity is another term, another concept that is very important when we discuss pathology of airway. Closing capacity is a volume at which airway collapse and closure occurs during respiration. So it affects gas exchange as it is related to the functional residual capacity. So under normal circumstances, FRC is more than closing capacity, which means if FRC increases or closing capacity decreases, as it happens in loss of lung elasticity, airway closure occurs at the end of normal expiration in dependent areas of lung. So this is very important when we are dealing with increased FRC, which we already mentioned, like in emphysema, bronchial asthma, like in cases of COPD. So you have to keep in mind airway closure. If it occurs at end of normal expiration, there will be problem with gaseous exchange. and atelectasis in dependent areas as soon as anesthesia induction is over is a possibility. And FRC and closing capacity difference is also reduced in infants and elderly. So when we anesthetize these extremes of age, we have to keep in mind about a potential lung collapse or atelectasis in dependent areas. How we manage all these things, we will discuss probably in the next session. Now, along with that, we need to discuss dynamic lung volume. Dynamic lung volume is measured during active inflation or deflation, expired volumes during a forced expiration of a maximal breath, that is forced vital capacity. We'll come to that in detail. Forced vital capacity is the total volume of gas that can be forcibly expelled after a maximal inspiration. During forced expiration, dynamic compression of intrathoracic airways occur, limiting both the rate of expiration and the total amount of gas that can be expelled. So in clinical practice, the significance comes, the volume of expired gas in the first second is measured as part of FVC measurement. From this ratio, FEV1 by FVC can be derived, which is a useful index for obstructive airway disease. Now, normal FEV1 by FVC is usually more than 95%. It declines with age. So 85% of FEV1 by FVC ratio should be acceptable in elderly patient. Now we'll come to the concept of ventilation. Ventilation is the process of fresh air gas reaching the gas exchange areas of lung. Gas exchange is dependent on the volume of gas moved in and out of lungs per minute. So this is referred to as total ventilation or minute ventilation, which is calculated by rate of respiration into tidal volume. The concept of dead space. Dead space is a volume of lung that is ventilated but do not take part in gas exchange. So dead space is divided into anatomical dead space and alveolar dead space. The anatomical dead space, as we saw earlier, that is conducting airways, and alveolar dead space are the alveolar that are ventilated but are not perfused. The sum of both of these anatomical and alveolar dead space is what we call the physiological dead space. We'll come to anatomical dead space. Usually it will be 2 ml per kg, that is measured by Fowler's method. I'm not going to details of Fowler's method because that is not very relevant here. It varies with changes in bronchial muscle tone, changes in position of head, neck, and endotracheal tube. The functional decrease occurs at low tidal volume when gas flow in airways is laminar. Now, the significance of all these things, I will reserve it for our next session when we deal with alterations in this normal physiology. Alveolar dead space, when we discuss alveolar dead space, you need to keep in mind that only fresh gas reaching the alveoli take part in gas exchange. So in each breath, a portion of vital, the tidal volume will reach alveoli because of anatomical dead space, that is VD. This portion is alveolar volume or VA. Now, alveolar ventilation, that is volume of gas per minute reaching alveolar space, is rate of respiration into alveolar volume. So, physiological dead space, normally we said alveolar dead space and the anatomical dead space are together the physiological dead space. In normal circumstances, physiological dead space differs very little from anatomical dead space and may be estimated using Bohr's equation. That is, Vd by Vt is equals PaCO2 minus PeCO2. That is partial pressure of mixed expired gases divided by partial pressure in alveoli. Partial pressure of mixed expired gas can be measured from a collection of mixed expired gas in a large bag. And partial pressure in alveoli can be taken as equal to that of arterial partial pressure. Physiological dead space is dependent on anatomical and alveolar dead space. Now, alveolar dead space increases when lung becomes better ventilated than perfused. The conditions, again, will come to that in detail. We'll come to distribution of ventilation. Now, traditional concepts suggest that both ventilation and perfusion are gravitationally determined, with optimum ventilation and perfusion occurring at lung bases. Now, this is what we all were taught and what we all were, um, uh, uh, for all practical purposes, this used to work fine. But more recent data and ideas and clinical evidence suggest that ventilation and perfusion follows a centripetal distribution because of histological architecture. The main determinant of regional perfusion difference is regional vascular resistance, which is influenced by changes in lung volume, asymmetry in branching of airways, and vascular tree rather than a gravitational gradient. Now, um, again, the evidence of this is found in literature due to paucity of time. I'm not going into detail, but the relevance of this will come when we discuss clinical case scenarios. Now, discussing the basic concepts, we'll come to gas flow in airway. Gas flow is the ease with which a gas moves through the airway depends on one, airway resistance, and second, the pattern of gas flow. Airway resistance is determined by pressure difference between the heads of airway, delta P, and the resistance of airway to gas flow R. So flow is delta P by R. Delta P is the difference between atmospheric and the intra-alveolar pressure, the pressure gradient, and R is the resistance of airway determined by the radius. The factors affecting the airway resistance, the most important factor is the lung volume. So increase in lung volume decreases airway resistance. So this is evident when we see patients with high airway resistance voluntarily increase their FRC by position. We can see an asthmatic in an acute stage sitting with arms stretched behind back or holding or clutching on an object, clutching on a window pane or something above. That increases the intrathoracic volume, or pursed lip breathing, which also increases the lung volume. Another important factor that affects airway resistance is bronchial smooth muscle tone. Histamine release also affect airway resistance because H1 receptor cause bronchoconstriction. Density and viscosity of the gas, example, helium oxygen mixture is used to decrease the density and viscosity. When there is a lower airway obstruction because of mucosal edema or plugging or presence of foreign body, when there is an upper airway obstruction that usually happens in sedated or unconscious state, in anesthetized state, when there is an upper airway obstruction, in anesthesia, even otherwise, resistance doubles during anesthesia, mainly due to reduction in FRC. Now, pattern of gas flow, we all know there is laminar flow and a turbulent flow. Laminar is smooth with circumferential layers of gas sliding across each other in the direction of flow. There will be turbulent gas flow, which is disorderly flow with random eddy currents and whirls occurring across overall direction of flow. Again, the clinical significance we'll discuss later. Another important concept is work of breathing. Work of breathing, as I said, is normally expended in inspiration, as expiration is passive, and work of breathing is required to overcome the elastic forces of lung, that is known as the compliance work. Work of breathing is also required to overcome airway resistance during movement of air into the lungs. Now, work of breathing is also required to overcome the viscosity of the lung and the chest wall tissues. This is known as the tissue resistive work. The compliance work and the tissue resistive work is increased in restrictive lung disease. Airway resistance work is increased in pulmonary obstructive disease. Work in expiration becomes necessary in forced breathing, increased airway resistance, or tissue resistance. Now, in conditions like asthma, expiratory work is more than inspiratory work. Now we'll come to the control of ventilation. Control of ventilation, we have the central control in which medulla, pontine, brainstem, and cortical level control is there. Medulla, usually the inspiratory and expiratory control is from medulla. Pontine, we have the pneumotaxic and apneustic center. And above the brainstem, we have the limbic system, and certain level of control exists at the cortical level. Now, in medullary centers, the inspiratory and expiratory pool of neurons exist in the medullary center. They function by a system of reciprocal innervation. So, which means as activity increases in one center, a rising level of inhibitory activity is relayed from opposite center, resulting in reversal of ventilator phase. Inspiratory pool is located in the dorsal medullary reticular formation, which is a source of basic ventilator rhythm. You can even call it as a pacemaker of our respiratory system. Expiratory pool is located in the ventral medullary reticular formation. So what happens during inspiration is there will be a gradually increasing activity that is relayed from expiratory pool that inhibits the inspiratory pool until expiration begins. At the same time, inhibitory activity is related to expiratory neurons from inspiratory pool until expiration ceases and inspiration begins. So this is what we mean by a reciprocal innervation system, where activity in one center increases, rising inhibitory activity is relayed from the opposite center. So there will be reversal of roles in each of these neural pools. Now this is where the ventral and dorsal inspiratory and expiratory and the neural groups are located. The pneumotaxic center and the apneustic center is located. You can see a pre-Botzinger complex that is also mentioned here, that is seen in mammals, the functionality of which is not very clear, but it plays a role in maintaining the rhythm of respiration. We'll come to the Pontine centers of respiration. The Pontine center is the pneumotaxic center that is located in the upper pons. This fine-tunes ventilatory rate and the tidal volume to minimize respiratory work. So even in the absence of a pneumotaxic center, a basic ventilator rhythm is maintained by the medullary inspiratory group. So the pneumotaxic center is what fine-tunes the tidal volume that regulates the work of breathing. Now, in apneustic center that is situated in lower pons, the apneustic center prolong the inspiratory phase by acting on the medullary inspiratory pool of neurons. So when there is a section just immediately above the center that gives rise to apneustic breathing. Apneustic breathing, as you know, that is a prolonged inspiration with brief expiratory effort. There is also a control of respiration by higher centers. Now, cerebral cortex affects breathing pattern, but the precise neural pathways is not known. But we all know we can voluntarily hyperventilate and hyperventilate up to an extent where uh, changes in APG is reflected. So that is managed by a cerebral cortical control. Now, in extreme emotional states, you can see there is a change in pattern of respiration that is controlled by a limbic system and hypothalamus. Now we'll come to reflexes in control of ventilation. So reflexes are mediated by specialized receptors, central and peripheral chemoreceptors. There are chemical and baroreceptors in airways. There are J receptors and stretch receptors in lungs. There are Golgi tendon organs and muscle spindle in respiratory muscles. Coming to chemoreceptors, the central chemoreceptors are situated bilaterally about 0.2 millimeter beneath the ventral surface of medulla and are highly sensitive to changes in hydrogen ion concentration. There are also peripheral chemoreceptors which are found in carotid bodies that are located bilaterally at the bifurcation of common carotid artery, aortic body in arch of aorta. Now, efferents from these pass through vagus to dorsal respiratory area. Now, this act as oxygen delivery sensors to brain. So, um, these sensors are highly sensitive to oxygen, and since the connections afferents are directly to the dorsal respiratory area, the respiratory rate can immediately be altered depending on the sensor's sensitivity. Now, there are chemical and irritant receptors. These exist in the mucosa of upper airways and trachea and help the lungs from inhalation of injurious substances. These reflexes initiate laryngeal closure, apnea, hyperpnea, and bronchoconstriction to an irritant stimuli. There are also pressure-sensitive receptors that are located within smooth muscles of all airways, and they help in control of the depth of respiration. There are J receptors found in alveolar walls close to the capillaries. Their stimulation causes rapid, shallow breathing or apnea. The J receptors or juxtamedullary receptors are thought to be involved in pulmonary edema. This is sensitized in response to edema that occurs and due to irritation of lungs. Now, there are also pulmonary stretch receptors which are located in smooth muscles of airways. They inhibit inspiration in response to lung distension and slow ventricular rate by increasing expiratory time. Herring and Brewer reported this in 1868. Now, this is weakly present in humans. It is not activated till the tidal volume is more than 1.5. Now, this is very evident when we see patients on CPAP on ventilator. We can see that even if the lung is distended, in normal human beings or in normal tidal volume, this reflex doesn't happen. So probably this is a protective mechanism that is meant to prevent excessive ventilation rather than a component of normal ventilatory control. There are also Golgi tendon organs. This is seen mostly in intercostal muscles. The Golgi tendon organs are also involved in pulmonary stretch reflex when lungs are distended. The chest wall is stretched, thereby activating the receptors. Now, Golgi tendon organs signals to brainstem to inhibit further inspiration. Muscle spindles, they are located in inspiratory muscles and diaphragm. They control the depth and effort during inspiration. Muscle spindles become active when particularly intense respiratory effort are required, as in airway obstruction. So these are also responsible for giving a sensation of dyspnea. Now, um, um, keep in mind the mighty five variables upon which we are going to discuss the alterations that happen in the mechanics of ventilation. The mighty five variables are pressure, flow, volume, resistance, and compliance. Now, these five factors or five variables are intimately intertwined and it determines the mechanical process of breathing, whether it is during relaxed breathing or during arduous exercise, or if even if it is supplied by a ventilator. Now, um, these five variables, I have just presented a basic of these variables, and we shall continue in our next class the gas exchange, the transport, the pulmonary circulation and its control, the distribution of perfusion, the shunt and the shunt fractions, and alterations that happen in anesthesia and ventilation. Now, um, I have just brushed upon the very basics of these concepts, which is of very importance, and the concept should be very clear when we discuss uh, the major concepts that is relevant to us in the next session, which will be uh, the next weekend. Thank you for your patient listening. And one more thing, um, um, there is a real paucity of the time available for me. I'm very sorry about that. So I had discussed with Dr. Vinil. If there are questions in chat box, I would be happy to take up the questions with the next session, if it is okay with the seniors.
No issues, Dr. Sajin. We'll take up any questions in the chat box in the next session because they are covered the basics only.